Well, hello everyone. It's Dr. Isabelle Amigues. Today we're talking about PMR or polymyalgia rheumatica. It's a very interesting condition, and at the end, you will understand how we make a diagnosis of this and how we treat it, and how you can feel better very fast. The first thing is I'm going to give you a case, and you're going to see what I mean by what is polymyalgia rheumatica. So, a woman that comes in that's over 77, let's say she's 72 years old, and she developed basically sudden onset joint pain. But it's most like it's not really joint, it's actually like more like a muscle. And it's basically this realization that she's not able to put anything up or to do her shampoo her hair. And so she starts with this and then starts developing some pain of her hips as well. And again, more like the muscle, the side. And her primary care physicians gave her a little bit of prednisone, 15 milligram daily, and her symptoms completely went away. She had had fevers, that went away. She had started losing weight, that went away. She had started having some sweating, that went away. And the pain of her shoulders and her hips went away completely, okay? So that's the typical presentation of polymyalgia rheumatica, or PMR. The thing is that PMR is an inflammatory disorder. It's a rheumatologic inflammatory disorder, and we don't actually know how and why it is there. There are some hypotheses that maybe VZV is related. Some work from the University of Colorado, Professor Maria Nagel, started looking at the association of VZV, which is the shingles or zoster, and associated and saw that maybe it was related to PMR and GCA, giant cell arteritis. But it's not been proven for sure. It's just something that we're wondering. So it might be related to infection. We just don't know. And the way it presents is that our patients are, so first of all, it's usually women more so than men of white ancestry, so Caucasian, more like the Northern Europe. And it's usually after 70. We consider that if you have a PMR, if you have symptoms of PMR before 50, it is not PMR. So you have to be at least 50. And if it's earlier than 50, it's something else most of the time. But usually it's 70 to 75 to 80 years old. The pain, the typical presentation is pain that involves the shoulders, the hip. It's not so much joint pain. It's usually more like muscle and tendon pain. So it's the soft tissue. In fact, if you were to take an ultrasound, and we started doing this, if you ultrasound that, you see that there is inflammation of the tendon much more than there is inflammation of the joint itself, okay? So again, like that sensation of like it's the muscle, it's just this tightness of the muscle. I can't move my hands up, I can't function. The pain is inflammatory. So what does that mean? It's worse in the morning. It's associated with morning stiffness, and it improves with exercise. That's like the typical type of pain of inflammatory, of polymyalgia rheumatica. Then the way we diagnose this is basically we're going to rule out anything else. Why? There's not actually one test that's going to tell us this is PMR. Why? Because if you actually really think about it, it's an inflammation of the tendon, the muscle, not so much the joint. So there's nothing to look in the joint itself. And then there is inflammatory markers that are elevated. So the ESR, the CRP are elevated, but there's no antibody, right? It's not like rheumatoid arthritis where you can have a rheumatoid factor or CCP. So that's not going to be positive. So what we want when someone has those symptoms is that you want to rule out gout, you want to rule out pseudo gout, you want to rule out rheumatoid arthritis because that can be a presentation, okay? And then what you're doing is that you're doing a trial of prednisone. And that's probably the number one way that we make a diagnosis of PMR is a spectacular response to prednisone at a dose that's actually pretty moderate, 15, 20 milligram. If we give 15, 20 milligram and our patients are like perfect, then we have a diagnosis of PMR, okay? And so then if it's only PMR, the way we're going to do it is that we're going to try to decrease the prednisone. And if we see that we can't decrease the prednisone, that the symptoms come back, what we do then is that we can add a biologic, okay? And then we'll decrease the prednisone, and then we slowly try to decrease the biologic. What becomes interesting, wow, I'm starting to have some interesting comments here. What's really interesting is the association of PMR and vasculitis. So vasculitis is an inflammation of the vessel. When someone has PMR, so this pain that's inflammatory of the shoulders and the hips, it can be so if you start having fevers, headache, or eye changes, you want to really double check that there is no GCA or giant cell arteritis. That is an inflammation of the vessel. If you have an inflammation of the vessel, we have to treat with much higher dose of steroids. So you don't want to just give prednisone 15 milligram. You want to go 1 milligram per kilogram. And then you're going to try to back off. You might need a biologic a little bit more. The reason it is an emergency is that you can actually become blind from this. If there is inflammation of the eyes, you may not actually see it. The eye may not be red, but you would see it if you actually go to the ophthalmologist. They can look in the back, okay? That is super, super important. There's not a lot of issues if you wait in rheumatology, but that is one of the big emergency. So if you have PMR, or if you think you may have PMR, and that you have a headache, that you have eye vision loss, please call your ophthalmologist right away and you say, this is an emergency and I need to be seen today. If they won't see you today, then go to the emergency room and tell them that, because we need to give you high dose of steroids, okay? That is probably the one thing that is the most important that I may teach you today. Okay, because PMR, really easy to treat. We'll back up from treatment as soon as we can, slowly, and we'll get you to full remission like that. But GCA, giant cell arteritis, if you don't manage this as soon as possible, there is a potential of harm on your body that can be really much harder to reverse. And so that is the one emergency that I would say, okay? So again, PMR, we usually treat with just low dose of prednisone and then we back off and we see if we can get you off of anything, that's the goal. And GCA, much higher dose of steroids. Again, we have biologics, so much more targeted treatment in case we see that you need more than a couple of months of prednisone. Okay, so we do that. All right, so I hope this is helpful. I'm going to respond. I'm going to see there's a couple of comments. I love when there are trolls. I guess I've made it. If there is a troll, you are dumb. Well, if I'm dumb, I'm really sorry that you feel that way. And I think you are unkind to share this, because I'm here sharing some of my knowledge with my time. And this is to help everyone, really, because I believe in the empowerment of people. And I'm really, really sorry that you're hurt, because really that shows me that you're hurt and that you're in pain. And I really apologize for that. And I'm really sorry for you. And I hope you do better. And I hope you get some information from this account. And if you do not have to follow this. Okay. Thank you so much. And hi, Teresa. Hi, White Tea Free Boy from California. Hi from California. That's wonderful. And hello, everyone that usually comes in. If you're watching this on replay, don't hesitate to say hashtag replay. And I will see you next week. And as always, if you want to listen to more, all of those are living on Rheumatology 101 by Dr. Isabelle Amigues, Amigues, on YouTube. And we also have UNABRIDGEDMD podcast where you can actually look at those as well. All right. Until then, thank you so very much. And I will see you next week. Bye, everyone.